to presenting you minimizing deleterious facial effects caused by non-invasive ventilation mask early treatment. I came from Porto University in Portugal. This is the place where I work. It is a dental faculty, and I am here because I published a small chapter about facial effects caused by non-invasive ventilation early treatment in congenital muscular dystrophy. I work with several persons, some of them pediatric dentists, other nutritionists, physiotherapists, development pediatrician, and also pediatric pneumologists and neuropediatrics. We all want to get children better. And I think that there was something missing about non-invasive ventilation. Non-invasive ventilation is something important, and it is indicated for different types of treatment, including for patients requiring respiratory support in periods longer than 12 hours. And it is used to treat central sleep apnea and or severe obstructive sleep apnea. It is also prescribed for patients who have difficulty breathing, neuromuscular diseases, and heart diseases. Children with obesity and Down syndrome, obstructive sleep apnea, or neuromuscular disorders are part of a group of risk patients where respiratory muscles are weakened or the airway is obstructed. They may be treated with non-invasive ventilation, including nasal, oronasal, or facial masks, generally supported on the maxilla. The harmful effects of these masks depend on the type of mask applied, the places where the forces are applied, the intensity of the forces, their direction, and the time of action of the forces in question. If this mask does not rely on solid structures of the face, causes severe deformations in patients, especially if they are young and with the skeleton to form and easily moldable. The substrate on which the forces act is important because a hard bone of an adult male does not deform in the same way as the soft bone of a baby or a child. I come to talk to you about a girl, a 5-year-old girl that visited me. She could not walk, and she was always with his mother, and his mother bring her always, and they were very collaborative. We took some photos, stand in the chair, and we see that she has a progenic profile, and we see also a retrusion of the maxilla. A photo from the mother shows a retrognathic profile and some lingual protrusion, like pseudomacroglossia. We took a teleradiograph, lateral radiography of the cranium of this female that has congenital muscle dystrophy. There is a severe maxillary retrusion, a cross-bite, open bite, and vertical growth of the mandible. The panoramic X-ray is the best exam to test the child and parent collaboration. For a child who does not walk and needs constant help from the mother to position himself, the radiograph is of sufficient quality and should not be repeated. We can see the permanent teeth and also the temporary teeth. And when we see the mouth of the child, we see that she cannot hit very well because the teeth do not go together. It is very easy to see for anyone. And of course, I imagine that the probable cause is the mask that she used. This is described for a long time, but there are not many books or images about what happens. Well, this girl used, at 15 months, the child started using non-invasive night ventilation with a nasal mask. This mask was used by the child, so that there is a good adaptation of the nasal mask without air escaping. A strap adapts the silicone to the face, anchored in the neck or nape, easily creating a retrusive force to the jaw. If we see a photo of the child before using the mask, we can see that she has a convex profile without maxillary retrognathia problems. That's why I say that the mask is causing the deformation. And another photo of the same child before using the non-invasive ventilation device. Convex facial profile with a noticeable distal occlusion of the mandible. We see the mandible is back. The middle third of the face is well developed and proportional. So we decided to do something for this child. First, we decided to cut the cycle of mouth breathing. Normally, mouth breathing makes a lower position of the tongue. And with the lower position of the tongue, a vector, constrictive vector, is created and maxilla gets smaller. So we decided to put a fixed appliance, which is easy to clean, acts in a short time, and does not need intense cooperations from parents or from the child. And normally, the appliance is going to expand maxilla, and then the maxilla, which is very small, stays big. And we open the maxilla not. We open the maxilla not by the teeth, but separating both hemimaxillas. expanding from the apical base. And in this place, we will have bone in more or less 2 or 3 months. Here, there is no bone, but after there will be bone. So what we have when we prepare the suture is an open maxilla, and also the bottom of the nasal part is bigger. So we open the maxilla, and after 2 to 4 weeks, the maxilla that was very small and that could not afford the tongue could not go to this place, but it goes to the appropriate position. And when it goes to appropriate position, it generates a growing vector. So what are the benefits? Well, normally it's not only mouth that grows, but also the lower part of the nose. So we increase the drainage of secretions. We have a better airway if used. We have an increase of attention and activity. We have a better general development. We have a better general health with less hours of work loosened by the family. And many mothers tell us for these cases that they show a lower incidence of rhinorrhea. They say it was the first summer my son had his nose completely without secretions. And remember that we did not have occlusion between maxilla and mandible, that there was 1 centimeter difference between maxilla and mandible. And then we put an appliance that makes the maxilla grow. And then this appliance has also some hooks. And we can, in this hooks traction, we make traction the maxilla. It's what we do. And then we put this kind of mask to traction the maxilla. So in neuromuscular disorders, we know that the removal of non-invasive ventilation often leads to death or serious complications. So the interface is essential and cannot be discarded. Deformities are severe by disease, and without the non-invasive ventilation interface, patients die or are tracheostomized with higher morbidity and mortality. So we want to keep the mask. We want to keep it, but we change the forces. The important thing is the joint work of non-invasive ventilation that allows survival and quality of life, with the support of the pediatric dentist to optimize minimizing the consequences. The mother wanted to make a testimony, and she said that as soon as the appliance was placed in her mouth, within days, there was a massive notoriety in her teeth spacing, mouth opening, and ogival palate alteration, widening and less depth, to the point where the teeth fit aligned correctly, teeth with teeth. And the the mother testimony says that the changes were notorious at all levels: respiratory, with better breath; speech, better diction; eat, chews more firmly and quickly; crack some foods; drinking faster; and also aesthetics. We can see before and after teleradiograph, and we see that all this maxilla has come here. And now we don't see this step in here because we have everything better than before. And of course, the child feels that the child is better and the convex profile is winning. And so, as a conclusion, I say that whenever non-invasive ventilation use is prolonged and at an early age, exclusively maxillary support should be avoided, if possible discarded, preferring the use of a mask with multi-site facial support, or in some instances, total and better distributed loads, if necessary, tailored to measure. Pediatric dentistry and orthodontics play a vital role in promoting health and development in children with neuromuscular disorders and other non-invasive ventilation problems. A pediatric dentist is a vital element in the medical team that follows this patient and should always identify, prevent, and intercept these problems to achieve proper development. So please try to have full masks, try to not to charge too much only the maxilla. If you have cases, we may work together, and if you have doubts, you can ask me now or tomorrow between 14 to 16. I am going to explain this in ventilation and its relationship to child development. It is a pleasure to be with you. I'm available for questions.
Well, I believe there are no questions yet, but still, we're very grateful for that you shared this outstanding work. Thank you very much, and especially
Thank you.
For sharing these tips. After all, I mean, about the mask and etc. Thank you very much.